Okay, hello everybody, and welcome to today's Insight webinar on behalf of IPC Partners, the Healthcare Infection Society and the Infection Prevention Society. Today, very exciting day. We have Dr. Nneoma Okeke to talk to us about big data, AI, and risk stratification in IPC. Hi, Nneoma.
Hello, hello. How are
Hi,
you all
Phil.
doing?
I'm well, thanks. How are you?
Okay, so before we get going, Nneoma, I was just going to throw a random question at you because you're in a bit of a niche role in kind of this IPC data AI sort of world. How did you end up here?
That's a good question. Well, I ended up in IPC, a smooth transition from being at UKHSA, and GSTT in particular has a very rich data set, which I wasn't expecting when I came into the post. So it just piqued a lot of interest as to what questions could be asked, and being it was like going down a rabbit hole and figuring out I could actually do quite a lot with the data in front of me. And of course, with the boom of LLMs and all of the other popular AI tools that are out there right now, it became quite easy to quickly pick up and learn about all the different things that I could use and do. And yeah, here we are. Combine a lot of gusto with a lot of inquisitivity, and here we are.
Yeah, and you started out with a medical degree, didn't you? And kind of pivoted to an epi sort of role.
Yeah, exactly. So having that subject matter expert domain really was pivotal in making sure that I actually understood what I was doing when I'm coming into handling data and AI. And there's actually a little bit of a gap because you'd find majority of the people that are working with AI models, they tend to have studied computer science related degrees, not necessarily coming from a completely different angle where you learn about what you're working with first and then upskill and then get those tools to start manipulating it, which puts me in a much better position because I don't have to ask people what Candida auris is or what is the difference between this sample and that sample. And it makes it a lot easier to start to interpret the results that you're looking at in front of you.
Yeah, and you've touched on the potential language barrier here, really, haven't you? You know, you get your data people who understand the data, the clinical people who understand the clinical, and never the twain shall meet. So part of the role is being a bit of an interpreter between those two worlds.
Exactly that, yeah.
So Phil, how would you rate your data and epi skills?
Poor. But I think my AI skills are improving. I was thinking about, what we would discuss when we kick the webinar off, and I think that I'm using AI more than I ever have before, and I've probably had an explosion in the usage of it in the last 12 months, and I'm definitely finding it helpful and useful. I think where I need to work harder and learn more is around, how that fits in with the big data, and how we can use AI to effectively kind of manage and provide us with insight into trends and analysis on mountains of data that we ultimately do generate within IPC. So yeah, really interested to hear the talk today.
I mean, I've never used AI myself. I don't know about anybody else, but so it's not true. I'm using it more, but it's annoying me more and more because it's kind of infiltrating every aspect of my life now. I'm craving some human interaction. So it can definitely go too far. Okay, well, look, before we hand over to Nova, let me just run through a few bits of background about the Journal Club. If you've got your phone out, have a look at that QR code. It'll take you to the live schedule of Insight webinars and Journal Clubs. So what we're trying to do today is provide an expert overview of this highly relevant topic, but we don't want it to be one way. We want to generate discussion. So do please put your questions into the Q&A box as Nova goes through her talk. Very often the questions flood in at the end and it's quite difficult to prioritize them. So please put them in as Noma goes through. Also use the upvote function so that the popular questions will get asked first. We want to provide opportunities for CPD, and this is a CPD accredited event. We also want you to exercise your critical thinking skills. So don't take anything Noma says without analysing it and working out for yourself whether you think it's right or wrong. We want you to go away from here feeling emboldened and more ready to do your own independent research and study. And we hope that this is an energizing environment with a little bit of fun from time to time. Just to let you know, the event is recorded afterwards and made available online, so you can catch up and share it with your friends. So with that, I'm going to stop sharing and hand over to Nneoma to talk to us about big data, AI, and risk stratification in IPC.
Thank you, John. Okay, just let me know when this screen is up.
Yeah, we can see that.
All right, good. Okay, so good afternoon, everybody. As John has said, I am Dr. Nneoma Okeke, and I'm going to be talking to you about how we are proactively utilizing our big data to prevent healthcare-associated infections. So before we start, let's talk about what exactly big data is. The name kind of gives it away, but it's basically referring to extremely large, complex, and fast-growing data sets that we can't efficiently store or process or analyze using the methods that we're used to, such as normal SQL databases or Oracle databases or spreadsheets, for instance. So what we need when we're using big data are distributed storages. Essentially, we need parallel computing and advanced analytics to extract meaningful insights. That's a lot of words, so let's put some pictures up. So what we're used to looking at is, if you're thinking about data, you're probably thinking about an Excel spreadsheet with words on, numbers, whatever have you, in a nice neat line list. But really, what we are looking at when looking at big data are complex types of data. So we will have some data that is structured, those that you would see in Excel spreadsheets. We would have log files, which tend to be notes, so they're semi-structured, so they could be clinical notes, for instance. And we also have unstructured data, so these could be images. So all these different types of data sources need to be stored and analyzed somewhere. And those are where we use big data solutions, storage solutions. And again, what I mean by distributed storage is we have different places all over the place, all over wherever they are, all working at the same time, rather than having one computer pumping and trying to get your processes sorted. We have multiple, and they're all working at the same time to basically help us get to the end goal. Think of it as if you're using only one computer, you might crash it, it might not ever load. If you've ever had a really, really large Excel spreadsheet, for instance, you might notice it starts to drag, it starts to get really slow. It's very similar in that regard. So because we're dealing with really big data, we need multiple brains. We might break that Excel spreadsheet up into different bits so that it can work properly. So when we talk about big data in healthcare, we're talking about all the varied and vast, continually expanding information that we are collecting. So we have a digital footprint. Why is there so much data? So the NHS records about 1.6 million patient interactions every day. So that's about 18 every second. So for as long as I've been talking, we've already recorded well over 100 cases just in the NHS alone. At GSTT, we had 3.05 million patient contacts, which lead to about around 8,000 a day. And remember, for each of these interactions, we're producing multiple data points. So if a patient would come in, we would collect their name. We might collect when they last traveled. We might collect the last meal they ate, whatever their symptoms were. We would take their blood pressure. Every single thing that we type into the system is a data point, and it is stored and it needs to be processed. Now multiply that by all of the different patients we're seeing. It gets big very quickly. So where do we get this data from? So we have electronic health records, which are the ones that we are most familiar with. And in there, typically, if you have combined ones, such as at our trust, you will have your lab test results in there as well. You could have separate databases for medical imaging. You might have a situation where some patients might be put on physiological monitors, and that data is collected as well. Prescribing and medicines data is a really rich and important data source as well. And one of the biggest and overlooked ones are all the admin and operational records as well. It really does add up. So the opportunities we have are quite vast. We can unlock insights to support safer and more personalised and proactive care. We can drive improvements in service efficiency, resource planning, and patient outcomes, and ultimately enable innovation in AI, predictive analytics, and population health management. Whew. Okay, now, is anybody familiar with these characters? A quick hands up will be fine if you are. If you're not, these are characters from a really popular children's book that I really enjoyed called Where's Wally? And essentially the goal is to look in a sea of people, lots of distractions, lots of different characters, and find them as quickly as you can, especially if you have somebody next to you. Who's going to find Wally first? So quick exercise for you. I want you to look at these characters and I want you to type in the chat when you see them, okay? All right, so type in the chat when you see any of them. You can write their name down or just write seed. I'm going to give you 20 seconds. Okay, so a couple of people have seen. Good, a lot of people have seen. Good. All right, we'll come back to that in a minute. But I want you to bear in mind how many people you saw and how many people I asked you to see and how long it took you to find them. Okay, so what is machine learning? Machine learning is a type of artificial intelligence that uses algorithms, aka instructions, to learn. It's almost like a recipe book. So it spots patterns and trends in large data sets that would be impossible for a human alone to detect. So in healthcare, machine learning doesn't replace clinicians. I need this to be very clear because this is one of the bones of contention with AI and clinical practice. It doesn't replace you, but it complements clinical expertise. So it offers predictions and insights to support better decision making. So essentially, it uncovers hidden signals in data that can help predict risk, personalized treatment, and improve patient outcomes. So just for you to know, I won't go too deep into the machine learning types, but there are three main groups of machine learning, and what we tend to use in healthcare is supervised learning, which is essentially labeled data. So we are showing the computer something. This is a cat, this is a dog, this is a cat, this is a dog, so that when we show it a picture next time, it can easily say, oh, that's a cat based on what I've learned before. Okay, so we are training it based on what we have supervised it to learn. When it's unsupervised, it's looking for, it's using its own brain to figure things out. Okay, so what is the problem? Healthcare associated infections in the NHS. So there are many areas to address when it comes to improving health and safety. However, as John said in the beginning, I'm in infectious disease, so that's my focus right now. So what is the problem? We have patients that come in for treatment, but unfortunately, they may acquire an infection during their stay. So according to the UKHSA's PPS, this most recent data, 8% of patients that come to an acute trust will have a HCAI. This increases to almost 17% in acute specialty trusts, and is around 16% in ICU. So it's quite a high burden. And it's something that we really do need to tackle because it has increased morbidity, mortality, and healthcare costs associated with it. So what is our solution? Risk prediction. So our traditional interventions are well known. What we do enhanced cleaning, point prevalence surveys, isolation, to name a few. But the issue is these are blanket measures. They're not necessarily tailored specifically to patient groups who might benefit from different or earlier interventions. But how would we know who they are? We know that there are several factors that are associated with an increased risk of HCAIs, such as certain comorbidities, length of stay, the age of a patient, procedures they may undergo, treatment regimens. It's well documented in the evidence. You would find so many risks that are associated with HCAIs. So what is our solution? Risk prediction, machine learning models. So what we can do is essentially classify these people based on what we know, based on the data that we have on them, into different risk groups. This will be dynamic. So it's something that will update with each new data point that comes in. So with new lab results, for instance, if they have new devices attached, this will all be considered in the data in the machine learning model and update their risk category. What this does is it will enable proactive prevention before the infections develop. So we would be able to see that patient A is of a higher risk instead of waiting for them to get that infection and then doing something about it. Again, this is just an overview of how that would be done. We would collect that data, process the data, create variables, train and test the model. This will be deployed into the real world, and then we'll go ahead and test and validate. So right now at my trust, we are in the process of trying to get this started as a pilot study and I will update you in due course how that goes. So scenario 1, this is what we're all probably very used to, the reactive approach. IPC nurses are reviewing cases, actioning infection tags, and piecing together connections between patients. Eventually, they identify an outbreak in Alpha Ward. As a result, the patients may need to be cohorted, or the ward may even need to be closed to contain the issue. There's extensive testing and tracing that is required before reopening. After much investigation, patient A is identified as the likely index case and receives enhanced treatment. However, this process is largely reactive. It depends on recognizing infections only once they have already spread. So this is what it looks like. We have Alpha Ward. Right now, we don't have any oversight of what their risks are. That's why they're all in blue. While we still don't know what's going on with their risks, something has changed. If you have seen something change, just put your hand up. Okay, see, exactly. So we've noticed that while we have no actual visual overview of what's going on with this patient, the patient in the second bed on the top has seemed to be colonized or affected with something. There is clinical suspicion, and that will lead to testing. However, something else has also happened. Have you noticed? The 2 bottom beds as well. They've also got them now. We still don't know because we're not walking microbiologists. We would need to take samples and tests. Okay, we don't have any overview. We don't have anything giving us that foresight. That positive result from the initial patient leads to us screening the ward just to check if there's been any spread. And as you can see, this is probably worst case scenario, just to exaggerate the point here, but it has spread to almost everybody in the bay. Okay, so that's what the reactive approach would look like. So in scenario 2, we have the proactive approach. What we do is patient A is admitted on day 1. Based on underlying factors, for example, they might have uncontrolled diabetes, they might have an indwelling catheter, transfer from residential facility. These are all factors that would be considered in the machine learning model. The model will rank them, and they're already on admission ranked as a medium risk. With the addition of their clinical observations that are collected during the hospital, these are more data points that are being collected and updated in real time. That upgrades them to a high risk. Now, without doing a single microbiological test, we already have foresight that this patient potentially could end up with a HCAI. This alert is immediately flagged to the IPC team, who review these high-risk cases via a dashboard. The patient will be prioritized for enhanced IPC interventions, such as side room placements or whatever else they feel they deem necessary for this particular patient based on their specific risk profile. And this is all done before the results are even available. So when the lab results confirm, or if they confirm infection, the patient's already contained, we've prevented ward closures, and we've prevented widespread disruption. So what does that look like? So this is the same Alpha Ward, but now we have a different view. Everything's not unknown anymore. And that same patient that initially we had found out was positive for whatever that infection was, has already been admitted with a medium risk. So we already can see when we're comparing the patients, this patient is medium risk, a higher risk than others. So we are paying closer attention to this patient. It could be on a watch list, for instance. As I said, once those data points come on, it's dynamically updated, and within a day, they've already been triggered to high risk. The IPC team intervenes. They say, right, we think this patient needs to go off into a side room. We need to do preemptive isolation and just do some screening and make sure everything's okay. So they take that patient out. They do enhanced IPC. They block that bed until screening is completed. As you can see, everyone else is still low risk. And what they found is when they put that patient in this side room, lo and behold, they actually did test positive for whatever it is that we're saying they're colonized or infected with. Okay. So what this approach does, it gives us the foresight that we wouldn't have ourselves, because we cannot possibly process the hundreds and millions of rows of data that we would need to process to get this kind of information. So just to give you a visualization of what this would look like on a dashboard. So you'd have your patient, you have their storyboard, and you'd be able to see all of their different bits, their chart notes, their allergies, and then somewhere there you would have their risk. In this instance, we're just going to be looking at bloodstream infection risk. So you'd see the patient is admitted on day 0, they have a low risk. As time goes on, by day 2, they have a medium risk because things have changed. Potentially, they've been given certain interventions or devices have been put in there, or maybe they have a new diagnosis. All of these are factors that are considered in the background by the machine learning model, and therefore the probability increases and categorizes it as a medium risk. By day 8, this person has been pushed to a high risk, and at this point, you could then start to think about what interventions need to be done to make sure that this high risk doesn't turn into an actual infection. Okay, remember, this is not a diagnostic tool, but it's to complement clinical practice and allow IPC teams to navigate in a better and more effective way. Okay, so this is just showing what it could look like when we have different models for all of the different HCAIs. So we have our respiratories, we have antimicrobial risks, we have BSIs. There's so many different categories. They would all need their own separate models, and they could all have their own risk profile on a patient's storyboard. So for instance, in this patient, you can see that while they're low at BSI risk, they have a medium respiratory risk, and AMR risk is unusually high. So what these scores would then mean is within IPC teams, they would be able to sit down and decide, right, if we had a patient who had a high risk for BSIs, what would we do? If we had a medium risk, what would we do? A low risk, what would we do? And for instance, with high risk, they might choose to do sterile barrier precautions during catheter insertions. They might choose to do daily chlorhexidine bathing, or maybe even more, depending on whatever your local policies would be. They might choose to do a daily or more vascular review of their access devices. So many different options. The point is they have the tools, they know what they would necessarily do. It's just about figuring out how do we prioritize who we do this for, when we do it, and who is it going to be the most beneficial for. So we have so many additional applications that could be considered. So you could use algorithms that would detect location-based risks. For example, those that have higher infection rates in particular bed space areas, which could be linked to environmental factors, such as those that sink closer to sinks. They might have higher levels because of biofilms. They can act as a safety net by monitoring patients' prescribed antibiotic combinations that increase the risk of C. diff infection, which will enable earlier intervention. Or during winter pressures, for instance, risk stratification based on triage data and initial observations could highlight potential respiratory infection sources before they cause wider outbreaks. So the possibilities are numerous. If you can ask a question and the data exists, which in most cases it's quite robust, especially now, then you can do something about it. So what are the benefits of AI-driven risk predictions? So we would have targeted prevention. We identify high-risk patients early, and we can reduce these infections before they occur. We would have smarter resource allocation. So like I said, we do have the tools, but it's all about giving us that extra knowledge so that we can organize what we're going to do and how we're going to do it. So we'd be able to direct staff time better, manage isolation rooms better, cleaning efforts, and target them where they're most needed. Personalize the patient's safety. So right now, like I said, it's a blanket approach. We can't necessarily say this person may need these extra steps, whereas this person won't, because we don't have that foresight. However, with this kind of approach, we'll be able to tailor interventions to individual risk factors rather than relying on that one size fits all. And lastly, that informed decision making. So we provide infection prevention and control teams with real-time data-driven insights, and that will help guide their strategy. So these are just a couple of future directions. So as I mentioned, in our trust, we are currently pushing this through to do a pilot. And what that means is we will integrate it with our Epic dashboards. And this will be something that pops up on our patient storyboards, and they'll be able to use that to direct their IPC interventions. You could also have this in a real-time national surveillance point of view, where you would harness data not just within one trust, but across the NHS, which would help detect outbreaks and respond earlier and faster. Then wider adoption across NHS trusts. So scale-proven models beyond pilots and routine practice across the health service. And of course, collaboration. So this would you could strengthen partnerships between clinicians, data scientists, and IPC specialists to ensure that models are accurate, usable, and clinically meaningful. So in conclusion, big data and machine learning leads to personalized dynamic risk assessment. Early intervention means safer patients, fewer HCAIs, and empowered IPC predictive tools to guide smarter, proactive decision-making. So from countless interactions, all those small interactions that feel like they don't mean anything and they can't produce anything, we create big data, and with the right tools, we can turn these into big impact for our patient safety and outcomes. So just before I go, come back to the Where's Wally slide. So hands up if you found all 4 before I change slides. Be honest with yourselves. Good. No hands. Good. Right. So reason I put this up here is because I'm trying to explain a point. So when you put this into whatever model you're using, I put this into ChatGPT, it found all of them within 2.5 seconds, less than 2.5 seconds. Okay. Why am I bringing this up? Because the human eye can only do so much. Imagine these are all of the multiple data points that you would have on one patient. You might know that uncontrolled diabetes doesn't help. You might know that age is a factor and increased length of stay is a factor, but there is so much going on, not only with that patient, but with your several other patients, with your personal lives, with everything around you, that it would be near impossible for you to look at a patient, look at what you see at their records. And again, this is only what you're seeing from the front end, and be able to make that kind of informed decision. Machine learning models can. Machine learning models will take in all of those data points, millions and millions and millions of rows of data points, and churn it and give you something meaningful. You did find those in the end, you would have, but it took you a lot longer. Why not use the tools that we have to help us do our job better, faster, and smarter? Thank you.
Thanks so much, Nneoma. Fascinating presentation. I think from the minute that you started talking about the amount of data points that we generate within the NHS, that's staggering. And obviously there's a lot to play with. But yeah, really good presentation, thank you, and lots of food for thought in terms of the potential of this in the future. We've got a lot of questions, so John and I are going to do our best to get through them. Just a reminder that people can use the Q&A box to ask any questions. So Claire asks, is the machine learner, in inverted commas, one data collector, and who inputs the risk or the risks?
Is the machine learner one data collector, and who inputs the risk? Okay, so the machine learning model is essentially built off of code. Okay, so what this code does is, so imagine all of the data that we have is stored in a massive, massive, massive data lake, and it's just sitting there. It doesn't have any instructions on what you should do with it. So a code is written and we say, hey, from this data, I want you to tell me the length of stay. I want you to tell me, or rather bring back for me, because it's already there, the age, the sex, the drugs that they're on, whatever your interests are. That list, by the way, is formed from evidence-based research. So whatever the evidence say is relevant to increasing the risk of HCIs, those are the things that are considered for the machine learning model. So that's why the subject matter expertism is important, because you would know what to pull. It may not be as helpful to pull things like, there isn't very much that isn't really relevant, but it may not be as important to pull postcode data, for instance, when you're looking at HCIs, as it is to pull data on whether they've had a line in, for instance. So you pull all of that data with the code. So the code is written, doesn't change. You get that, you get the data out, you put it in a machine learning model. In this case, we are using a model called Random Forest, if you want to look it up. And what that model does is you first split your data that you have into 2 sets, a training set and a testing set. And that training set is what we teach the model. We say, hey, use this and learn. And then we will test and see how well it learned with the testing set. So once it's learned and it's gotten all of its kinks out, that model is then applied to new data. So all the data that is already in your system. So the machine learner is not a person. It's all in software. It's all automated. It's all code. So once you've written the code, tested it, you've refined it. There's several steps involved. I'm just trying to make it as digestible as possible. But once you've gotten that into a form that makes sense, then it can then be used to look at future data and categorize them accordingly.
Thanks for explaining that, really clear. Maybe just one follow-up question. You talked about having the 2 data sets. and the test data, how do you evaluate how well it performs when it looks at the test data? How do you evaluate that?
Really, really good question. So the reason we do that is because we already know the answers. So what we're doing is we're testing on data we already have the answers for. So we're running it on, so let's say we have 100 patients. We take 80 of them. We know exactly who had a HCI and who didn't. We know their whole history. We know everything about them. But what we're going to do is say, hey, look at these 80 patients, learn. I'm going to show you 20 patients in a minute, and I want you to tell me whether or not they get a HCAI. So once the model has finished learning, you say, hey, look at the test one and tell me what you found. And then it will say, okay, out of these 20 patients, I found 3 that would possibly have a HCAI. And then we check because we already have the answer. And we can say, oh, actually, yeah, there were 3 that had a HCAI. So you're quite accurate. Or maybe there were 4. So you've missed the mark a little bit. So that's how we'd be able to see, oh, you're on track, or oh. And then with that, we can then start to refine it and make it a lot more closer to what we would see in real life.
Very clever. Okay, thanks, John.
Okay, thanks, Nneoma. While you were just running through that first question with Phil, I put a flash poll up, and the question was, does your IPC team include a specialist with a focus on data epidemiology? And the response from almost half of the live participants here, no, in fact, it's just switched to exactly 50-50. So 50% of IPC teams do have a specialist, 50% do not. Does that surprise you, Nneoma?
It's more than I thought, to be fair. That's a lot more
Yeah,
than I
same.
Yeah, that's a lot more than I thought. Because hospital epidemiology is not, it's a relatively new specialism in the UK. So I would be interested to know about those that put yes. Connects me with your epi. Let me see what they're doing. Let's learn from each other.
Yeah, agreed. And I'm surprised too, but I'm encouraged by that. But I think the reality is probably if you're in the 50% that doesn't have specialist data and epi, pretty much all of what you've spoken about is going to be out of reach for now, right?
Not necessarily out of reach, because you don't need to, again, like I said, I upskilled from medical doctor to medical doctor data scientist. So it's not impossible. So far you have knowledge of what you can do, the world is your oyster. If you have that interest, you can train up and be that person that you need to be in your team and start from there.
Okay. But a brilliant presentation, by the way. Forgot to say.
Thanks.
Phil, back to you.
Yeah, thanks. It's a really good question from Jamie. One of your future directions was to scale proven models. Maybe you touched on this previously, but what needs to happen for a model to become a proven model?
So many things. Again, like I
Okay.
said, within our trust, we're lucky enough to actually have an entire AI team. So I'm relying heavily on them to help with the whole scaling and processing side of things. I know the code, but there are several other steps that you need to jump through before you get to the point where you can push that through for use by stakeholders. So unfortunately, I don't have the answers that you want right now, but ask me in a year's time. Things might be different.
Okay, so good question from Sangam here. So machine learning, the perception from the questioner is that you have to be quite directive in the details that you provide to machine learning to keep it on track and to avoid it beginning to hallucinate and go a bit feral. So is there a risk that a kind of trained machine learning approach might be too narrow and therefore might miss new trends or unexpected things that we weren't expecting when we were doing the training and the testing?
That is a beautiful question. Really, really good question. The answer is always yes. There are always going to be potentials of not getting it 100%. But historically and traditionally, especially with healthcare data, using supervised learning techniques has always been preferred simply because you're more likely to see a horse than a zebra, if that makes sense. Things that happen always happen. You aren't necessarily going to randomly have a new factor that pops in and just changes the risk profile that we have been documenting for years and years. So when it's things that we have well established, we all know length of stay is associated, we all know age is associated, we all know having a line-in is associated. Those things don't necessarily tend to change as much as the newer, maybe more sexy and interesting things that we see out in the media. These are well established for years and years. We know exactly what we're dealing with. So with those models, it's a lot more recommended to use the models that will essentially say, this is what you're looking for, work off of this, which are the supervised models. But what the question was asking was about unsupervised models, which again can be explored. There are no wrong answers to this, and it would be interesting to see what an unsupervised model would do in such a scenario.
Thanks. There's a question here around, what the implications are in terms of, from an IPC perspective, about what AI determines the course of action should be. So do you think there's a case for AI and big data telling IPC teams what should be done with that particular patient and determining them? So should they be isolated? Should contact precautions be applied, etc.? Or do you think that that's still the nuance of IPC is necessary for that?
I think that's where the nuances are. So I think a line needs to be drawn as to what you're going to allow AI to take over. It's the role of the IPC team to make those decisions. They have the clinical expertise, they've seen the patient, they have more understanding as to what is more needed for that person, which is why I feel the intervention should be very specific to the team. They should come together and talk about what they think is most important when it comes to the different risk groups. Of course, this can definitely be funneled down to AI, but then we're now headed into the territory where it's like a conversation of, if you feel AI can do this for you, why do we need you here to do the job? So once you start to cross certain boundaries, then it starts to increase a lot of questions and scrutiny, and that's one barrier that I personally wouldn't advise crossing. This is just supposed to facilitate what they're already doing, because it's not something a human can physically do. We're using multiple millions and millions of rows of data, updating it. We're not computers. So I feel like we should use computers for what computers are meant to do and use humans for what humans are meant to do.
That's a really good answer. I completely agree about drawing that line as well, and using our specialty within IPC to make the right decisions. In terms of like what that line looks like, I mean, what kind of parameters would you put in there in terms of where does AI stop? Does it stop in the decision making around the treatment of the patient, for example?
I think personally, once you start to ask yourself if this is taking over something I've already learned or something I was doing previously, you should start to ask yourself whether or not this is something you should really be doing with AI. If it's taking over something you learned and you took all this time to learn in nursing school, for instance, and you're trying to hand it over to AI, then you need to start asking yourself the question of why, what's going on, because you're going to start to de-skill yourself. You're going to start to make yourself a lot less relevant. What it should do is give you the opportunity to use the tools that are coming in and improve on what you already know. Now you get to master exactly whether or not it's octenidyne or chlorhexidine that's better. You can start to ask more important questions rather than looking for how to palm off more of what you already know onto AI and de-skill yourself.
Thanks.
Okay, Nneoma, look, all the tricky ones are coming out now, so apologies in advance. So Azul is asking another really good question, that flagging the infection risk of the patient through an automated or semi-automated route may bypass the traditional consent process, so that we might accept from a patient wishing to share their data with a group of other people for the purposes of their care. Do you have any privacy concerns here? And if so, what are they and how may they be allayed?
This has been such a popular question. First of all, NHS does have an opt-out consent policy. So if you choose to opt out of having your data used for anything, you will automatically be removed from anything, including the haircut tool, which is what this is called. Secondly, I think it's important for the teams to actually explain to the patient that this is for your benefit. If you're opting out of having yourself risk categorized, this is not a diagnosis, because one of the main issues that people have come to complain about, what if this affects their health insurance? What if this affects their life insurance because being put as high risk, low risk? This is not a diagnostic tool. That needs to be imperatively clear. This is to assist clinicians to do the best for you. If you come across as high risk, it gives them the ability to say, oh, I have a reason now to put this patient in a side room over this patient, or I have a reason now to increase the amount of enhanced precaution measures I'm using for this patient. It's about protecting the patient and reducing health inequalities, hidden health inequalities that we can't see, but the machine can. So to answer your question, yes, if they choose to opt out, they absolutely will be opted out. However, it should be made clear to them exactly what they're opting out of. And their data is not being used for anything. The data is just being used to inform a new mark. It's just like, for instance, if you check the dashboards on your patient's records, you might see a flag for a certain infection type. That's not new information. It's just being pulled from where it's stored and it's coming up, right? This person has MRSA. It's a similar thing. This is being pulled from data that has been churned from your own data to say, hey, this patient is high risk. Okay, so it's not going anywhere. It's being processed within the same system and being pulled through so that the clinicians can see and act accordingly. But in summary, if they want to opt out, they are more than happy to do that.
Yeah, I guess there's a related question, isn't there, around consent, because there may be some new risks that we might need to communicate to patients when we start using AI to support our decisions that we haven't had before. You may have a chance that AI may miss something, but we may have to include that somehow in consent for procedures if they're using AI in a certain way. Can I ask a related question about regulation? Because I'm aware some AI-informed decision-making is now classified as a medical device, depending on where you are in the world. And do you think the regulatory framework is about right, or does it need to do some catching up?
It's being modified as we speak. So like I said, the tool we're building is technically, because when we first started this project, it was considered, all we would have needed to use was a Jerry process, which is essentially the permission to use data, secondary data, and to do bits and bobs. But now it needs to be processed as a medical device, like you mentioned, and that's a whole different bucket load of regulatory requirements. But when you think about it, it actually is a medical device. It is helping facilitate, treatment, choices of treatment, even though it's not a diagnostic tool, but it is helping with that workflow. So I 100% believe in protecting the patients and their rights and their data, and making sure that we go through all of the steps that are necessary to make sure that everybody's being treated accordingly. However, I do worry that sometimes there could be certain restrictions due to these fears of backlash that would hinder our ability to progress. As of right now, I haven't seen that, but it is something that I'm conscious of.
Okay, maybe going back a step. I think a lot of people are interested in AI, maybe a little bit scared by it as well. If you were going to use AI in healthcare and you hadn't used it before, where would you encourage people to start?
AI in healthcare. I'd first encourage you to start by learning what AI is outside of ChatGPT and friends. Because right now, when people hear AI, they think large language models, and that's it. And those large language models are ChatGPT, Claude, Copilot, all of the ones where you type bits and it gives you bits back. They're great and everything, but that is where a lot of the risk lies. They're essentially web scrapers. So it's a free-for-all. Data is, not very protected. When we're talking about machine learning, it's in-house. It's not going out of these four walls. It's a model that is built based on data within the infrastructure that you're building it on, and it stays there and it's safe and protected. So if you want to learn more about that, first start by learning about the different types of artificial intelligence, machine learning. Then you can go on to learn about large language models if that interests you as well. And I would start there and build up from there. It can get a lot worse But start with machine learning models. Like I said, the model that we're using is called a random forest. And essentially what that is, it's a decision tree. So, you know, when you have a decision, do you like me? Yes, no. But we have loads of them. So did they stay longer than 5 days? Yes, no. Did they stay longer than, and so many of them come together and they average themselves out and we get predictions. So it's constantly updating, constantly changing based on the data that's being put into it. So I'll start by learning about what machine learning models are separately to what LLMs are and take it from there.
Okay, so thinking about some infrastructure and resourcing, Zara's asking about computing infrastructure required to support this level of computing. Will it require dedicated cloud space resources, or could it be supported within existing, often a bit creaky NHS infrastructure?
No. So like I said, GSTT is in a unique position in which we have a lot of the infrastructure that we need to do this. We've recently moved to a platform called Snowflake, which is great for big data management, and it allows us to scale up our computing requirements depending on how much we're processing. So long story short, no. If it's a simple, basic kind of thing, it would be very restrictive. You would need to invest in the infrastructure first before you'd be able to use that. However, if you're using it as a product, so for instance, if we were to complete it and sell it, then that's a bit different because you're not processing as much. We're just applying the model to what you already have and giving you an answer, a risk band.
Thanks, Nneoma. Is there anything you can share around whether or not AI has made an impact on transmission and infections in your own organization or experience?
It's all really new. I really
Okay.
wish I had more of an answer right now. For us, like I said, we are beginning our pilot this year. So I will have answers hopefully within the next year. If I come back next year, I should have something to tell you. But it is something like, again, the thing that takes the most time are all the regulatory bits, all the ethics and making sure you're ticking all the boxes and you're using it the right way. But we do have an MDT together and we are going to start working on that and hopefully be able to get some data that will show whether or not that is working in our favor.
Sounds exciting. Just related to that then, are you aware of any published studies or evidence that have shown that yet? Or are we still just in that initial step before we can start to generate the data?
There are some.
Yeah.
I'm not sure if they're about HCAIs and what was the question? What was the
Whether or
field
not
they were
there's
interested in?
there's data to show that AI is reducing infection or transmission.
I can't think of any off the top of my head. I think
Okay.
again, it's a really new sphere, and I have no doubt that it will. There's no doubt in my mind that it will. It's just about people doing the work and publishing so that people can see the answers.
Yeah, I mean, that's
Thanks.
sort of one of the most difficult questions you could choose to answer is, does this reduce transmission HCI? We're thinking, you'd be thinking multi-center cluster randomized controlled trials. So I think that's probably future next step stuff. There's definitely some evidence around AI informed clinical decision tools, improving diagnosis and decision making around, for example, antimicrobial prescribing or generalized diagnosis. So there's definitely a body of literature out there for sure. Okay, are there any NHS approved apps that might be relevant to our sphere in terms of infection management? Is there anything out there off the shelf that we could lay our hands on that you're aware of, Nneoma?
I don't think there's anything that's ready yet, but there are things that are coming soon, I believe. It's a really new sphere. It's one of those things where healthcare data is so heavily protected. It's not something that is people wouldn't easily allow you to start manipulating it to build such tools, whereas in other spheres, they've gone leaps and bounds. But yeah, you have a lot of things to consider when it comes to data protection in healthcare. So that's just why we're a little bit behind the curve. It's not that they won't come, it's just we've got to make sure you pass all of the checks and balances before we get to that.
A lot to do. Maybe looking towards the future then, do you see AI, big data becoming more embedded in our day-to-day within infection control and healthcare?
Oh, absolutely. I'm betting my bottom dollar on it. I'm hoping so. Yeah, definitely. I mean, it would be such a waste. It would be such a disappointing waste if it hadn't been used in a meaningful way. We have access to so much data that's just sitting there and being stored and not really being used for anything, whereas it can be used to really change the lives of patients. So it would be a disservice to our patients if we didn't try and use that for their benefit.
And do you think related to that, there's an increasing number of corporate partners, industry kind of picking up and coming with AI solutions?
Of course, yes. You know, big pharma's going to step in. Yeah, I would if I were them. They already are, yeah. So it's a hot topic. It's getting while it's a baby. It's in its infancy stage. So this is the best time to strike, if you ask me. Get yourself up to date, learn more about it, ask the questions, try and find the solutions. That's how businesses are born. That's how industries are made. That's how patients are saved.
Okay, so trying to identify and address healthcare inequality in all its forms is one of the big focuses of our profession, as it is of everybody at the moment. You know, we're talking about it more than ever before, which is great. Is there a risk that AI-based risk prediction might inadvertently reinforce some of those biases or healthcare inequalities?
Inadvertently reinforce them.
Yeah.
Um, I think that's where it's important to continually retrain the model. Okay. So what the mistake a lot of models make is that they would build it once and just set it and forget it. Whereas things are going to constantly be changing. So you have to continually retrain the model, give it new information so that it's continually learning and changing. And it's like, oh, right, okay, there's this extra thing I need to consider, or maybe we can change the balances a little bit this way so that the script doesn't flip essentially when it comes to health inequalities and management. But at the end of the day, AI is not really, I try to avoid using things such as the stereotypical health inequality markers in data analysis, only because sometimes it will pick up a trend, especially when it comes to ethnicity or socioeconomic background, if you use the IMD codes. So yes, if you put those in there, it will tend to start to make a pattern and probably stick to that. But when you start to focus on raw facts in front of you, blood pressures, heart rates, things that are not necessarily traditionally linked to the known health equalities, then we should start to get a clearer picture. That in combination with continuing retraining the model should remove those biases.
There's a question around whether or not certain EPRs are currently trying to incorporate AI. I don't know if you can comment on that, or we would probably predict that they are in some shape or form.
It should be, yeah, definitely. Yeah, it would, like I said, it would be a waste of the data, and you would find a lot of these companies will put themselves in a position where technically they are the data owners because they just know how powerful it is and what they can do with it. So yes, they definitely will be using it and trying to make it into something that they can sell back to you.
Okay. Thank you, everybody, for all your questions, and a huge thank you to Nneoma for a marvelous presentation and a great Q&A as well. It's a really exciting topic to be involved in, and I'm sure we'll be hearing a lot more about it in the future. So just before we finish, we've just got a couple of slides to just run you through from some of our partner organisations. Our next Journal Club / webinar in this series is in 2 weeks' time on the 24th of June. That's in partnership with Gamma Healthcare. We'll be talking about a paper which was published in the Journal of Infection, Hospital Infection, around oxidizing disinfectants versus C. diff spores. And John and I will be running through that. You can scan the QR code, which will take you directly to the Microsoft Teams link. That's a QR code which will take you to all of our current and scheduled journal clubs and webinars. You can also have a look at the website for any other updates that you might see around things like blogs and other work that we're doing within IPC partners. Finally, from our partners, HIS, their annual conference is coming up in June. I've spoken to a lot of people this week who are going to be there. So it's the 23rd and the 24th of June in central London. You can scan the QR code there to find out more information. And I think the places are still available, but I'm sure they're selling out quickly. And also FIS, which is in Glasgow this year on the 24th and the 26th of November. So again, that's hosted by the Healthcare Infection Society, another really good conference. I think that's over several days as well. So another one to consider going to. And also you become a member of HIS, as we've talked about before. It's a small fee to become a member of HIS, and gives you access to lots of different things, such as webinars, talks, and their network of infection control and microbiology. So without any further info to share, a big thank you to Nneoma once again. Thank you all for listening and attending and interacting with us, and we hope to see you next time. Thanks all, bye.